Good evening, everyone. We will continue off where we left yesterday. We were discussing drugs of choice for depression. If someone has depression and they do not have another comorbidity, like we discussed yesterday, drug of choice would be an SSRI, escitalopram, or sertraline. Either of them can be used. Sertraline is most commonly used, and the SSRIs, the group in general, have fewer side effects and fewer interactions. Sorry, sertraline is the one that has been studied in various comorbidities, and it's one of the few drugs that's safe in most other comorbidities. Now, today we will discuss what medicine to start someone with depression on if they have a comorbidity. Um, if someone has depression and anxiety, drug of choice would again be an SSRI or SNRIs. Some clinicians prefer SNRIs because they target anxiety at the same time. However, it's been evidence that once depression starts to get or the low mood starts to get better, anxiety comes down too. So we can start SSRIs safely. SSRIs are again first line. SNRIs are alternate to SSRIs. If SSRIs do not work, we can switch to SNRIs. If someone has depression and they have a really bad insomnia with it, we would start them, or we can choose mirtazapine for them. We can also consider trazodone as an adjunct to an SSRI or another medication. Someone who has depression and chronic pain, or someone who has chronic low back pain or chronic neuropathic pain, we can start them on duloxetine or venlafaxine. Sometimes TCS can also be used for lower back pain with depression or without it sometimes. Someone who has depression and recently had a cardiac event, or they have cardiovascular disease, sertraline or escitalopram, we would avoid citalopram in them because citalopram has been linked to QT prolongation and it can cause arrhythmia, specifically in someone who recently had a cardiac event. Lastly, depression and diabetes or metabolic syndrome, we still use SSRIs because they're weight neutral. They do not cause a lot of weight gain. Sometimes they may cause a little bit of weight gain, but it's not that significant. Or we can use bupropion as an alternative. There are other conditions like chronic kidney disease. In chronic kidney disease, again, SSRIs are safe. We would avoid duloxetine in chronic kidney disease. We would avoid TCAs in elderly because of the risk of falls. Once again, the medicine that we start for depression depends on the patient's age, their symptoms, what are we trying to achieve, and their comorbidities. SSRIs are generally used as first line for almost everyone, but if there are other comorbidities, we can consider other medications. For example, SSRIs like paroxetine, they're contraindicated in pregnancy. So in pregnancy, we can use sertraline, or we can use other SSRIs or other medications. Once again, in pregnancy, not controlling depression can be more devastating than the side effects that or the teratogenicity that we anticipate with SSRIs or other medications. Therefore, if someone is pregnant and they have depression, their depression needs to be treated just like everyone else. The only thing is that we would avoid paroxetine, which has non-teratogenicity. I hope that clears it out. And we can move on to doing MCQs in depression.